And I have a patient that Dan has heard me talk about many times who is diagnosed with diabetes. She had one visit to see me that was allowed pre-deductible in her plan, but her insulin was not covered pre-deductible. Her statin was not covered pre-deductible. Her eye exam was not covered pre-deductible. Her foot care was not covered pre-deductible. And you should know as a clinician, for me, these are the services that I'm benchmarked on. So it seems so ridiculous that the services that are deemed to be high quality on the payment side are being discouraged on the consumer side. And if this is not bad enough, I'll tell you that my patient, after telling me she couldn't afford the drugs and wouldn't go to her eye exam, et cetera, she said to me, I'll either see you next year or when I'm in the hospital. So that has driven me, NPC, several NHC members, and a large number of members of the Smarter Healthcare Coalition to try to reform high-deductible health plan policy. So the next slide will basically tell you where the issue is. And while we like to point fingers in Washington about folks who cause trouble and potentially deny access to people who are represented by the National Health Council, in this case, it's for once not the health plans, not the PBMs, certainly not the health sciences companies. It's the Internal Revenue Service. Because health savings accounts, the jurisdiction is in the Department of Treasury, there were some regulations written when this was included in the Medicare Modernization Act in 2004, which created a preventive care safe harbor, which, because of Section 2713 now, every HSA high-deductible health plan must cover those services, not only pre-deductible, but cover them at zero cost sharing for patients. So when you see an HSA trying to market themselves as covering free preventive care, all HSA HDHPs have to cover preventive care first dollar. The problem is, and why NHC is going to be so important to me moving this initiative forward, is there are explicit regulations that say that chronic diseases aren't covered. So if we go to the next slide, this is what really meant, the next one. So in this IRS guidance, it says explicitly that any service used to treat an existing illness, injury, or condition. That is everyone in the National Health Council. You know, there is, as far as I know, maybe Eleanor could correct me, there is not a group in the National Health Council which is called totally healthy, all I'm doing is getting screened and all my tests are normal. So the HSA HDHP problem is not only a Mark Fendrick problem, it's a National Health Council problem, because if you have an existing condition, which I believe every one of your constituents has, they have to pay full price until their deductibles met. And as I told you, a substantial percentage of your folks don't have the money to cover their deductible, thus a need for a change. So the next slide is the potential solution that first Mike Chernow and I and Steve Parente, who's now waiting for confirmation to become head of ASPE, have been pushing this idea of a high-value health plan. So it keeps deductibles high on the services that we shouldn't be buying in the first place, which is what I think is an excellent use of high deductibles and high cost sharing. But what we've been advocating for now for almost a decade is to have the IRS amend the safe harbor guidance to allow voluntary coverage of evidence-based services for chronic diseases prior to meeting the plan deductible. So you're not forced to do it, but if you wanted to cover high-value services that would be outlined by many of your organizations, this would take the pressure off many of these patients. Next slide. So this gets us to a great policy success. We have bipartisan, bicameral legislation that if you're in government affairs, I hope you write down these numbers of the Chronic Disease Management Act. This is a bill to basically make the amendment that I just talked about. As Dan said, we've had multiple meetings with the Department of Treasury. We believe that this type of relief can be done either legislatively or administratively, which is why we have been keeping a parallel track to make this change. So I think I'm right on time to basically say, all right, we have the policy lever, we know the problem. You can imagine, for those of you who live in the world of PAYGO, or what is this going to cost me, people have been asking us for a very long time is, well, how much would it cost if we actually had a high-value health plan for chronic disease management medications. So thankfully, working with Kimberly Westrich and other folks from NPC, we have done this project to actually answer the question to key stakeholders about, would this break the bank? Would this be a small hit? And allow us to move the conversation in a little more granular way. So next slide. And I think some of these I'll skip over quickly. I think, Jason, if you hold this. So you know, again, reminding you the problem of lack of pre-deductible coverage. Next slide. And that the cost of financing improved coverage for pharmaceuticals was unknown. So this is the motivation. Next. So very specifically, our research questions were, how would pre-deductible coverage impact out-of-pocket spending, the spending on the plan, and the plan actuarial value, which is a measure used in the policy world of plan generosity. So the more actuarial value goes up, the more generous expenditures on coverage as opposed to administration, and vice versa. And specifically, we were asked by, if you just go back for a second, we were asked by several stakeholders that say we wanted to cover these drugs more generously pre-deductible, but we didn't want to raise our actuarial value, or we didn't want to impact our total spending at all. How much would we have to charge everyone else who are not using these drugs to keep our premiums exactly the same? Next slide. So we worked with the NPC team, most notably Kimberly and Bobby Du Bois and our colleagues at Optum, and decided that we couldn't include everything. And I understand that there are organizations on this call that are not represented here. We had to draw the line somewhere, largely with some input from CMMI. We picked 11 chronic conditions for this particular analysis that included 57 specific drug classes. And we started a baseline of the most common type of HSA-HGHP, which was one with an actual value of 74% and a deductible of $2,000. So what's important now is that until that deductible of $2,000 were met, we presumed in this analysis that people had to pay full price for their drugs for these conditions until they paid $2,000. And the comparison was we actually covered them on a pre-deductible basis, to which patients paid $5 for generics, $40 for branded non-specialty drugs, and 10% coinsurance for specialty drugs. Although we looked at a number of different plan types, this was deemed by our advisory panel as the one that seemed to be most likely that if plans were to cover the drugs for these 11 conditions, this would be the formulary situation that they would use. So next slide. So when you think about what happens when you cover something more generously, the impact on the plan or the payer can occur in three ways. And this slide, which is brought to you by the fabulous interns of the Center for Value-Based Insurance Design, kind of show you the three ways you might see financial changes with a change in cost sharing. So first is per service. So basically, as opposed to having patients pay more and plan pay less, under the VBID scenario, it just changes the burden of the single service from one party to another. The real effects of VBID that we've always looked for is not the per service change, but we hope that my mother would be right, that as you lower the cost sharing for high value services in this situation, people would use more, which is why from the very beginning we felt if people use more drugs to treat these 11 conditions, whether it be asthma or depression or rheumatoid arthritis, in fact, costs would go up, which could be problematic to some payers. Now, of course, there are these situations, particularly in the diseases we've chosen, that if you manage depression better, if you manage multiple sclerosis better, there will be offsets in terms of emergency room visits or hospitalizations. It's very important to point out that because we wanted to be conservative and make drugs look as bad as possible, in this analysis, we did not include any offsets. So any results I'm about to tell you are actually the worst case scenario if we prevent a hospitalization for severe depression, if we prevent a stroke with hypertension management, if we prevent a knee or hip replacement with better management of rheumatoid arthritis. We do not include these things, so take these results as conservative or worst case. So next slide. And I think this is what we did. I told you already, next slide, sorry. So this is what was kind of exciting to all of us because we really had no idea what would be the impact of this broader coverage for these 57 drug classes on a baseline plan that I told you about. And you could see that when you have the impact of pre-deductible coverage, the plan will actually pay $5 more per member per month. The patient, which motivates me, actually pays $4 less per member per month. And that nets out as a less than 1% increase in the actuarial value. But for those of you who are thinking, what would I have to do to my plan design to completely cover this incremental cost in these drugs, would only require a premium increase of 1.7% or an increase in deductible for everyone of less than $200. And given that most of you, when you talk to your constituents, they talk about how their deductibles are rising, we were very enthusiastic to see that these conservative estimates say that covering 57 drug classes on a pre-deductible basis that would lead to substantial increase in utilization of drugs and hopefully improved health and offsets down the road basically end up in the error term. So the expected impact is relatively small from a financial basis. Next slide. So I like to show this little build here that for most of you, if you were bringing this into a health plan or the CEO or CFO of a self-insured employer and say, we really want you to get behind, or if it were to come to fruition, that you would start covering more generously high-value prescription drugs on a pre-deductible basis, you would see in this graph to the right of this slide that it's barely noticeable in terms of what the plan paid per member per month would be. Next slide. So like all academics, and Dan knows this, I'd really love to have the opportunity if the policy goes through to studies in the field. But I wanted to make sure that before we get so excited and start marching on the Capitol Hill, which I encourage you to do, that you understand that there are some limitations that apply, is that if anything, we overstate the per member per month impact because one of the things that drive me crazy is that we don't know anything about the rebate scenarios that go on. Secondarily, the medical offsets, which in certain conditions we've studied specifically, would decrease the overall increase in AV and spend. And we don't have any information, of course, on patient assistance programs. And I think there are some organizations on the call today who come from those fabulous organizations that help patients get financial coverage for drugs they need. It is our real hope that policies like this would decrease the use of patient assistance programs and copay cards because people would not have to pay as much for drugs that they need. So there is an important limitation that may actually understate the impact, and that we do not look at new patients initiated indicated therapy, how that may change. And of course, there's the last caveat that we base this analysis on a standard population that our friends at Optum were able to pull together. It may not be representative of your plan, a public plan, a private plan, because demographics are always different. But this is, as I said, as conservative as can be. Next slide. So, and if you didn't, you should now know better, that the fastest growing type of health plan and the health plan that's most highly promoted by the Speaker of the House and the President of the United States, an HSA qualified high-deductible health plan, by regulation cannot offer pre-deductible coverage for chronic disease management medications. if we were to change the policy and allowed pre-deductible coverage at a typical type of formulary. So I'm not suggesting these drugs should be free, but I'm suggesting that generics should remain inexpensive, that preferred brands should remain accessible specifically for those who fail generics, and coinsurance should be low for specialty drugs because no one really wants to be on them and there's no overuse. If we make this happen, the premium increase is less than 2%, and if those of you follow the rhetoric of what's happening on the exchanges or other types of things, they're always talking about double digits. I think 2%, as I said, is in the error term, and if you were going to instead not impact premium but just add to the deductible for other services, it's less than $200 per patient. I think a very, very good trade-off given our try to move spending to more things that have been proven to help patients and away from things that don't. The problem is that you could do this in a commercial plan, you could do this in an HRA, a health retirement account, but you cannot make these pre-deductible changes allowable in an HSA currently. And as I said, myself and now the Smarter Healthcare Coalition members have been working for a decade to either do a regulatory or legislative fix. Next slide. So this is where I want to be, and I realize and intentionally have a fair bit of time for comments from the audience. I want to bring Fred Flintstone from the Stone Age to the Space Age. I want my patients and NHC constituents to have it be easy, not hard for them, to get the care that is clinically indicated. And what I'm seeing now is a large amount of frustration and, more importantly, a robust evidence base suggesting that high-deductible health plans do not, while they may lower healthcare costs a bit, they lower healthcare costs by reducing both high-value and low-value care. And in reducing high-value and low-value care, they're most impactful on people with chronic diseases like NHC constituents and those who are socioeconomically challenged. So it was very intriguing for me to hear from the Academy Health meeting that more and more people are understanding that cost sharing in general and deductibles specifically are a tax on the sick. And anything we could do from a policy standpoint, particularly one that has bipartisan political support and broad multi-stakeholder support to give relief to people with chronic conditions who need medications, the better. So I look forward to continue my work with NPC and NHC. And if there are any individual organizations who want to learn more about this study, if you just go back quickly, Jason, you could find the study here on the VBID Health website. And if you want to learn more generalities about our work to reform Section 223C2C of the IRS code, you could visit vbidcenter.org. So with that, I will turn it back to Eleanor and Dan, and I look forward to hearing from any questions or comments. Thank you very much.
Thank you so much. Oh, go ahead, Eleanor.
Thank you, Mark. I was going to actually say that I was going to turn it over to Jason to let us know if we have any questions that have come in through the chat line.
Yeah, thank you. So one question right off the bat for Mark is just, what was one of your biggest surprises when you're going through this study? I think you've covered it at length pretty much on the results, but anything that stood out to you specific to a particular condition?
No, I mean, that's a good question. I think what's really particularly interesting and optimistic to those people who worry about costs is that while my mother is right that when you make people pay less for something, they buy more of it, people are not going out and seeing adherence rates or people filling their prescriptions at 90%. And what we have seen in our VBID world outside of high-deductible health plans is even when we make high-value drugs free, the increase in adherence ranges anywhere between 1% and 14%. And I'm happy to let the audience know that an updated review of the literature on value-based insurance design on medication adherence will be published in the July issue of Health Affairs, so very much detailed. But so the counterintuitive thing, Jason, is about this is that when we make things more accessible, and if we do have successes, as I've talked about with Dan, in making this policy change. We're very happy to tell people who are worried about having the doors blown off on spending that they're barely going to notice, because relative to other parts of spending, pharmaceutical expenditures are relatively low.
Thank you. One other question. How would this interact with, and this gets to your point about some of the organizations who may help with, or assistance, I should say, for some of the patient services, but how would this interact with copay assistance / offset programs? Specifically, how would VBID principles, HVHV
interact? So I know the Patient Advocate Foundation's a member. I know. So I love these organizations because they know I want to put them out of business, and they would be happy to put out of business. So again, our fabulous VBID Center research associates have put together a full set of resources of what we call precision patient assistance. So as Dan and Eleanor have heard me talk about, I really find copay cards for drugs that have a generic equivalent to be somewhat egregious. But in my opinion, a huge majority of patients who need copayment and payment assistance are on drugs that they don't have any alternatives and they don't want to be on. So we have argued loudly, I'm not sure it's been accepted so much, is that if patient assistance is limited to people who don't have another drug alternative, I'd much rather have them get a copay card or a grant from an organization like PAF or PAN than have to have a bake sale or a Kickstarter, as I said. We have advocated for a while that it is our hope that the payers and the health sciences companies will come together and get our patients and NHC constituents out of this mix. It should not be incumbent, in my opinion, to have someone with multiple sclerosis or chronic kidney disease or whatever have to go out on their own as opposed to getting help to get care to which their clinician says it is absolutely necessary. So I think that if we could change this dialogue away from patient assistance for the small percentage, in my opinion, that's egregious, and really remind key policymakers that a substantial majority of patient assistance is for care that's clinically indicated, I think the better off we'll be in that situation, Jason.
Excellent, thank you. And this is more of a process question, but in terms of next steps and, sort of call it a 6-month game plan to that effect, how would you recommend folks, obviously learn more? I know you've mentioned a few things. We'll be able to share all the information that Mark has mentioned today in a follow-up email, but what do you think the next 6 to 12 months will be just related to these topics?
Well, I think all of you know that I live in Ann Arbor, and everything in Ann Arbor is about Michigan football, so I'm going to use a football analogy. Dan Leonard, who's been very gracious in advising me on this for almost the entire 10 years, I said, we're within the 20-yard line, 10-yard. We've been on the 1-yard line regarding this policy change for a very long time. So I would recommend that you either reach out to me directly through Eleanor or Eric, if he's on the line, to let you know about getting involved in our policy efforts and learning about the Smarter Healthcare Coalition. And so I'm hopeful that, literally this week, Jason, we're advocating for the Chronic Disease Management Act to be included in the Ways and Means markup. So if there's anyone on the call who has contacts with that committee, please help us move this legislation forward. And as I mentioned, Dan has been really helpful as at NBC, getting us contacts with the Department of Treasury to also follow that parallel track. So, Jason, I would love to tell you in 6 months that this was a done deal, but I think that what we really just need to do is get a broader voice to, A, the damaging impact that high deductibles are having on NHC constituents, and that there's actually a reasonable voluntary policy that starts a conversation to give 20 million Americans with chronic diseases potential relief from their deductibles for their high-value drugs.
Excellent. This is actually a question for Eric, if you're able to be on. I just unmuted you, but just from the NHC perspective, any thoughts on the bill specifically? I know that you've been able to get a quick look at it, but just wanted to see if you were still on and able to kind of get the NHC perspective on this. All right, I think I'm going to have to run to his office. I know generally, though, Eric had mentioned that, certainly supportive of all the provisions and everything like that. So something we'll continue to monitor.
Yeah, I think. Are you sure that Eric's unmuted? It may be a mute issue.
Ellen, why don't you go ahead? I think he's just on the computer.
Oh, okay. Well, Mark, I actually had another question for you. Can you help us understand, right, and help the folks from the various patient groups understand, when you're talking about high-value care versus low-value care, how is that being determined, and who's making the call on that?
I'm so glad you asked that, because you can imagine I've only gotten that question like 1,000 times and got that at the American Diabetes Association yesterday. So how I like to describe this, and Eleanor, we go back a long way, is I have started advocating for high and low value care, not in the area that you and I would argue about, but not even low-lying fruit that I describe that's below the ground. Services that have been deemed as quality metrics for decades that no one argues. That would be an eye exam for diabetes. That would be a beta blocker for people after heart attacks. That would be behavioral therapy and medications for people with major depressive disorder. And you know that since I started in this path, and now 15 years later, it's actually harder for a diabetic to get an eye exam than it was when I started, to suggest that we're losing the battle for the situations that there are no arguments over. Regarding low-value care, you're being very modest. Eric has participated, NHC, as well as other organizations on the call, understanding this need for cost neutrality and understanding the Star Wars stuff that's coming down the pike. I am lucky, and you are unlucky, that Americans spend up to 30% of the $3 trillion on care that we shouldn't buy in the first place. And Mike Chernow and I have put together something called the Task Force on Low-Value Care, which you and Eric have participated in, and why low-value care is so important, and why we use a multi-stakeholder evidence-based approach to not only identify high-value care but low-value care, is we need to get rid of some of these unnecessary services like population-based vitamin D screening and laboratory testing and other EKGs and things before cataract surgery and imaging for people with acute musculoskeletal back pain. We need to get rid of these services to create headroom to allow public and private payers to buy this fantastic but expensive Star Wars science. And I've written a piece on this in Morning Consult that I could have you share with your members, but we need a new model. And I completely have some sympathy for payers who say, they just don't have the funds to buy everything that's coming out of the Star Wars science lab. But I do believe that if we were to take a substantial chunk out of the care that we shouldn't be buying in the first place, some motivated by providers, some motivated by patients, it at least would give those payers a little more room to buy more of the things that you and I would agree that we should buy more of.
Thanks, Mark. One question, I think this will be the last one, and it kind of builds on what Eleanor just mentioned, but can you talk more about the 57 drug classes you studied and how they were deemed high value versus low? When are those without generic equivalence considered high value? I'm hoping that you have one. That is not a good last question. So that is information that people could find digging deeper onto our website. Is there another question in the queue, Jason? That was actually the last one, but I'll leave it to you for any final thoughts. You could look at the 59 classes, or as Eleanor's penultimate question is, why these 11 diseases? And I could have picked 5 diseases or 50 diseases. When I wrote my first bill with Senator Kay Bailey Hutchison and Debbie Stabenow, we picked conditions that were the 14th most common in Medicare, and then we wrote another bill that the 11 most expensive to Medicare. I think that the reason why I kind of passed on that question is if we start having dialogues about why did you pick this and not that, it takes away from the fundamental issue that deductibles, the way they're written now, preclude all services to treat chronic diseases. And I would imagine that questioner, whether he or she may not agree with my 57 drug classes, I hope they would agree that 5 out of the 57 were deemed to be high value. And I would love to hear from them about another 15 or 20 classes that we didn't include.
But the bottom line is that the drugs for these 11 conditions are currently not covered at all until the deductible is met in this type of high deductible health plan. And we believe that if we actually start getting HSA high deductible health plans to start covering these classes on a pre-deductible basis, those plans that can already do it that are not HSA qualified will either, one, become HSA qualified, or two, will start covering these same services on a pre-deductible basis even though they can't already. So I think, I didn't hear from any of the organizations on the phone saying, oh, high deductibles are not a problem for my constituents, which I believe that is true. And that if you have any other ideas besides patient assistance programs or the dreaded call to just lower prices for everything, which is, basically sailing through the wind, which is why we try to come up with this intuitive idea that's supported not only by both political parties, but a lot of healthcare stakeholders that tend not to agree with each other very much, which is why, if anyone wants to send me an email, which you could find through the VBID Center website, telling me why we should not move forward with this initiative, I'd love to hear it. My last thing I'll say, Jason, as I said it before, is I've been talking about HSA reform since HSAs were formed in 2004. No one has ever told me it's a bad idea to give plans the flexibility to voluntarily cover things like insulin and AIDS drugs on a pre-deductible basis. So let people pick what they choose, what's high and low value. The current situation allows coverage of none, and this policy would allow coverage of some. And again, I can't imagine that there's a single group, part of the NHC, that wouldn't like to see some flexibility to arise to allow them to advocate to health plans to cover more services on a pre-deductible basis, because the status quo, in my opinion, is not very good.
So, Mark, on that note, we want to thank you. This has been a great conversation, and we really appreciate you taking the time to meet with us this afternoon. I think that we got a lot out of it, and I would actually offer that if there's anyone on the line who has a case example of a situation with a high-deductible health plan that they'd like to offer as an example of their experience, please send it in to either myself or Jason, and we'll accumulate those. And that way it's something that we, as the National Health Council, need to know about or want to learn more about, and then we can also share those with Dr. Fendrick with your permission. So I want to thank the National Pharmaceutical Council for supporting us and taking part, and for helping us to pull this together. We appreciate that very much. And I want to wish everyone a happy rest of your afternoon. Thanks, Mark.